the COVID vaccines is probably the only situation where we are the non-playing experts. Uh, Very, very unusual for the pediatricians not to be involved in actual vaccination against disease. Probably this is the only situation where we are having a lot of knowledge about vaccinology, but we are now applying it mainly for our own selves, our colleagues, and our friends, and all the nurses and other workers who are working with us, and also looking at it in future of this vaccine. So we have the experts on this. So without wasting much time, I will now hand it over to Dr. Jagdish Chinappa to take over the session. And I'll request the people to conduct the session in about 45 minutes. I'll give an indication 5 minutes before the 45 minutes so that we'll have at least 10 minutes for the discussion and for people to participate. Thank you so much. Over to Dr. Jagdish Chinappa.
Thank you, Professor Ramachandran, for that wonderful introduction. At the outset, I must thank the government of Tamil Nadu, the IIP Tamil Nadu branch, and Dr. Balasubramaniam for inviting us for this very important session on pediatric COVID vaccines. My panelists, as you can see, are distinguished people. And is my screen visible?
Yes, sir.
Yes,
Yeah.
Jagdish.
Thank you. So my panelists have already been introduced. I think Dr. Jacob John, Dr. Sanjay Srirampur, and Dr. Sanjay Lalwani do not need any introduction to this august audience. So we'll straight away go in with the COVID vaccine. Basically, these are the three main discussants for today. Professor Jacob John, as you know, is from Vellore. He is a very prolific writer and a past president of the Indian Academy of Pediatrics, a retired professor, vaccine expert, and a WHO consultant. Professor Sanjay Srirampur is a consultant pediatrician, past CEC IIP head, member of the ACVIP. Dr. Lalwani is one of the premier researchers on vaccines in India. Basically, we will start this vaccine discussion by saying that we have got three groups of doctors and three groups of patients also. Basically, as far as doctors are concerned, very few of us are really against vaccines, but there are a large number of people who are skeptics. And there are some who are protagonists or who will promote vaccination. Now, what are the points which the protagonists or who say that all children should get the vaccine quickly say? One, they say that the significant disease burden in children, like adults, it's going to spread right across to children, right? And since it's going to be the third wave, children are more likely to be affected. So this is one of the hypothesis. The second thing is that if there is prolonged circulation of the virus in the community, it can promote dangerous variants of concern, and therefore you need to vaccinate children quickly. And finally, you have the costs of disease surveillance, testing, infrastructure, staffing, etc. if you continue with the disease for a very long period of time. And the only way you can bring it down quickly is by vaccinating. Now, if you look at the skeptics, the other thing is, of course, spread to the vulnerable population, the elderly and the people with chronic disease. Those who are skeptics come up with saying that trials in children are at a very nascent stage. We don't have any robust trials. The vaccines are not even authorized for use in adults as yet. Most of the technology that is being used for these vaccines are new technology. Like you had the mRNA vaccine, the DNA vaccine. The adjuvants are new, like what you saw in, let's say, the Novavax or even the Bharat Biotech vaccines are new adjuvants. Adverse events are not covered by compensation in any of our public health measures. And other thing is, children are at low risk. And why should they be subjected to some risk, primarily to protect adults? So there is a plea for vaccinating only high-risk children or older children who are likely to have disease like adults. And there is another statement which says that the natural disease produces a more efficient immunity than vaccination, which I'm going to come to in a little time. And the point is, right now we have some vaccines which may not be the best vaccines, and we may settle for an inferior vaccine and not allow the child to take a better vaccine in, let's say, 6 months' time. Finally, there will be issues of vaccine availability. Even now we have problems with vaccine availability, and we should still prioritize adults who are likely to get severe disease. And the other thing is that if you're going to spend a lot of money and logistics to mitigate the disease, you might use it for other long-standing child health issues. So these are some of the points which are for and against immediate vaccination of children. So first I will start with Dr. Sanjay Shirampur. We already heard from Dr. Tanu Singhal that children are not at great risk for getting the disease. Neither are they very important in transmission of the virus, as many studies from the school transmission have been done in many of the countries. So can I ask you, what are the significant problems with COVID in children?
Jagdish, if you look at whether COVID is a significant illness in children, we need to look at into two perspectives. Till recently, we thought that children will not get affected with COVID as much as adults do. But there are now studies which show, even the recent ICMR studies and the CDC data show that children are equally affected as much as adults in terms of infection. Though the second point is children below the age of 5 years, the incidence of COVID is less, but it is as much as it is in adults over the age of 50 years. So in terms of COVID happening in children, yes, it happens. Now, the second part of the question is it significant in terms of morbidity, the disease? There are well-documented studies all over the world which show that children are mostly mildly affected or they are asymptomatic. Now, this is in terms of the severity of the disease, and the presentation in children is also different from adults. Now, are children implicated in the transmission of virus? Children are implicated in the transmission of virus as much as adults, though children may not be super spreaders. But we need to take into point two considerations is that you have a large population of adults who are vaccinated, number one. Number two, a large population of children who are asymptomatic and they may transmit the disease. So this is my take, Jagdish.
Thank you, Sanjay. I would just also come in and ask you, since this is a new disease, do you think that there are some reports, long COVID in children with children affected by long COVID? That is, they are symptomatic about 3 months, 6 months after the COVID illness. So what is your take on that?
As of now, there is not much robust data of long COVID happening in children. We just heard Dhiren's experience actually. Children do not suffer from COVID or its long-term effects. There is no robust data, but children generally do not get long-term COVID.
Sir, Dr. Jacob John, would you come in and comment on that?
Let me say two things. Am I audible?
Yes, sir.
Yes, sir.
Okay. Let me say two things. One, that as far as transmissibility goes, it depends upon where the virus is amplified, in the lungs or in the upper respiratory tract. When it is in the lungs, even the air that you breathe out through the nostrils contain virus. But if the lungs are not infected, then the virus is not in the air. So why are we socially distancing to prevent transmission? Because the air that you breathe out or droplets that you produce when you speak are laden with viruses in adults, not so in children. Unless children have, we have prolonged contact with children, and children have sneezing, coughing, or snuffles, then they are infectious. Otherwise, they are not as infectious as adults, merely because of the fact that lung fluids do not contain virus in children. That it's a continuum from young towards 18 years of age. The second issue, well, I think I will stop here unless you have a specific question.
Sir, I think that's very clear that there is illness in children, but however, they are not as infective as adults. So that is the bottom line here.
Long COVID is, I think, more or less the same frequency as adult long COVID.
Yeah. So I think there have been some studies which have come from Switzerland just about a week back, which has shown that the prevalence is almost about 4%. 4% of children who have COVID land up with long COVID, lasting for more than 12 weeks. Sir, regarding this vaccine trials, we are coming to Dr. Jacob John now. Regarding this vaccine trials of COVID vaccine in children, there have been a lot of ethical shortcuts. They've been combining phase 2 with phase 3. Then point is about the informed consent. You're getting in. There have been accusations of children who are not able to give, or parents who are not understanding the informed consent process being included in the trials. Any comments on these?
Yes. Of necessity, you will expect trials not to include children from the beginning. So it's a gradual work down from adults to children, and in children, lowering of the age, 18, 12, 6, then 2, something like that. The ethical issue is not a very simple question. It's a very complicated issue. There is ethics in giving a vaccine that is not well characterized. There is ethics in not giving a vaccine which is safe and it promises protection, but you have not measured protection yet. Okay, there is a range of issues in ethics. So the normal rules of ethics do not apply in a pandemic time, and we need clear thinkers without any conflict of interest. And such people will have to make a decision. So it's not an ethical shortcut, it's an ethical modification that we require. Imagine if the vaccines were allowed by end of last year, how many lives could have been saved during the second wave? So ethics cuts both ways. There is ethics in doing things and there are ethics in not doing things.
So what you mean to say, Professor John, is that we are moving into a new framework of ethics which is going to fit into a public health response rather than individual rights. Am I right?
Absolutely right. That is, vaccine has two roles. One, to protect lives, and two, to control the infection so that everybody gets the benefit. Those who are at risk of death and those who are at risk of simply mild infection. Everybody gets protection. So the approach of these two are different. We always knew that a programmatic use of vaccine is for the latter purpose, whereas an individualized vaccine is for the former purpose. So as long as this vaccine is not licensed in the country for general use, it's only available for the government to decide what emergency use they will approve. So then it is the public health programmatic use of the vaccine that is currently going. I believe both companies have applied for full license, both Bharat and Serum Institute of India. When the vaccine, if they're licensed, then the question arises as to whether we should give the vaccine or not to individual children. We will not come to that if the questions arise.
The other problem which is there, Professor John, is none of the data which these trials have done is available in public domain. Still, it is with the government to bring this out. The phase 3 trials are not out as yet.
Phase 3 trials of the AstraZeneca is well known.
No, that is different, sir. We are talking about the Indian vaccine.
Indian vaccine. I've seen the phase 3 trial results. They have been submitted to WHO, to the government, and it's also pre-publication copies available. I can send it to you. Okay. It is more or less the same as this second analysis. It's against symptomatic COVID, it is 78%. It was within the 95% confidence interval of the second analysis. Okay, and even the first analysis. In terms of severe disease, ICU admission and mortality, 99%.
Okay.
Just like almost every other vaccine.
Right, sir. Thank you very much. Can we also just discuss quickly about the vaccines outside India? Because Dr. Lalwani will be discussing about the vaccines inside India. And the outside India, there are 2 vaccines at least which have been authorized for use in children. Recently, I think just yesterday, Moderna also got their vaccine for children authorized by the European Union. So what are the data? Do you think that the data which is available abroad is robust enough? I know for 12 to 18 it's available, but less than 12?
No data that I have seen in less than 12. And when they have used vaccine in the 12-year plus, they have identified a new side effect, some cardiac problem, pericarditis, myocarditis. It is not that infrequent. That is, it's about, I would think, 1 per 15,000 or 14,000 adolescents. I'm talking about the Pfizer vaccine. Moderna, we'll have to wait after it's rolled out, and then we will know. Fortunately, these are short-lived, self-limiting diseases as of now. Whether this has any longer-term effect on the heart health, we'll have to wait and see. So caution has to be applied for simply extrapolating from adult use to children's use. Since you mentioned about Covaxin, I can tell you that from immunological point of view, being a totally inactivated virus vaccine, it should have no additional similar adverse events that we are discovering with the other vaccines in this vaccine. That's the expectation. And so far, children above 6 have received their second dose in the vaccine trial of Covaxin. And I think it's about 200 or 300 children. So far, so good. Now they're going to give the second dose to children about 2 years. A lot of children have been given first dose. They're waiting for the second dose. So we will wait and see whether that pans out to be safe and effective. There, if efficacy can only be measured by neutralizing virus neutralizing antibody correlating with the adult virus neutralizing antibody, you cannot look for clinical vaccine efficacy at all in children.
Now, while we are at this neutralizing antibody, there are a lot of objections saying that this is not a good way of assessing a vaccine response because there are so many factors which could come in, and this may be just one of the factors. What do you say to that, Professor John?
Which virus neutralizing antibody?
Yes. Okay.
No, virus neutralizing antibody is the gold standard in terms of assessing protection. Okay. The anti-protein antibodies, whether it is N protein or spike protein 1 or RBD, they do not seem to correlate because it's simply binding that is picked up in ELISA. This probably is a quantitative issue, not a qualitative issue, because it's positive, it shows you are infected. So once infected, you must have certain degree of immunity. So that's not a clear picture yet. And of course, nobody is measuring cell-mediated immunity in any of these situations. So that also is an additional factor involved. But the gold standard for every vaccine before it goes to human trials is the induction of virus neutralizing antibody. And anyway, if there are new variants, how do you assess whether there is protection against variants? Again, you go for virus neutralizing antibody and you see the gradation against various variants.
True, sir. So, Dr. Lalwani, you have been at the forefront for doing trials of vaccines in India. So what are the likely vaccines which are likely to be available in India for children in the near future?
I'm audible?
Yes, sir.
Yeah. So if you look at the COVID vaccines which are licensed in India at present, is AstraZeneca, Covishield, we have Covaxin by Bharat Biotech, and we have the Sputnik by Dr. Reddy's lab, and I think to get licensed will be Zydus Cadila. Now, if you look at the pediatric perspective of the trials, what has been done is Zydus Cadila. The phase 3 trial for Zydus Cadila is through, and the children between 12 to 16 years were included in this trial. And I think so the trial is over, and I hope so that this vaccine could be licensed, the first vaccine in the pediatric population. Now, the only hitch here is it's a DNA vaccine, and logistic wise, the 3 doses are required: 0, 28, and 56 days. And you have a special injector which has to be used in the field when you are going to give this Zydus Cadila vaccine. That's number one. Number two, as far as the second license which could get through would be the AstraZeneca, because they have finished the pediatric trial in the UK population. And because of the relaxation of the DCGI, if the vaccine is licensed in European Union or the other unions, then they would not be requiring bridging studies to do in the pediatric population. This being a pandemic time, I think there would be an emergency licensure of the Covishield by AstraZeneca in India. And the third vaccine, I think the trials are just going to start in another week's time, is the Novavax, which is the subunit vaccine, and the technology transfer has taken place. And I think Serum Institute of India would start this Nasovax, which will become Covavax in India. So, and of course, we have the Indian-owned manufactured vaccine, the whole kill vaccine by Bharat Biotech, which also are in the phase 2 and phase 3 clinical trial. So that the vaccine which could get licensure first, according to the data available, would be Zydus Cadila above 12 years. The second, of course, would be the AstraZeneca if the UK trial gets through and there is no bridging study required. The Bharat Biotech phase 2/phase 3 studies are in, I think, few sites in India. And the last, of course, will be the Covavax or the Novavax. I think these are the 4 vaccines, but I personally think so. Now, even if the pediatric vaccine gets licensure in India, we are a long way ahead before really looking at the pediatric vaccination, because we look at the numbers getting vaccinated in India, we are far behind the desired numbers which the government wants to roll out. So even if the vaccine gets rolled out in India and they get the emergency permission to use in pediatric population, they would not see the light in year 2021 is what I personally think so.
Thank you, Dr. Lalwani. Just a few clarifications from your excellent summary of the data. I think the AstraZeneca vaccine, they are put on hold as far as small children are concerned, primarily because of the thromboembolic complication, which has been noted in young adult females. So
Yeah.
what do you think about that? Do you think that it's going to be easy to get this vaccine licensed in our country with the risk of thromboembolism, especially in adolescents?
Yeah, I think the trial for AstraZeneca in the younger population, there has been a hold because of thromboembolic phenomena. And I'm sure the DSMB board would shoot at that. When we started this AstraZeneca trial also, if in the adult population, there was a hold because of transverse myelitis associated, and the trial was hold for 2 or 3 weeks, and then there was a European clearance, and we restarted the trial. Let's look at what's the data coming out. But suppose if this trial has to go ahead and gets licensure in the UK market, I'm sure looking at the pandemic, the DCGI would look at whether to sanction or not. But I think the first to hit next month, of course, from the clearance would be Zydus Cadila.
So according to you, in this race of, we have 5 vaccines in the race, I think the front runners will be Zydus Cadila and Bharat Biotech. Am I right?
Yeah, another vaccine which Pfizer is conducting a trial in the US, where they have enrolled 4,500 children between the age group of 6 months to 18 years. And I think phase 3 studies are on. If the Pfizer vaccine, the mRNA vaccine, gets its clearance in the pediatric population, I'm sure, and if the vaccine would be available to in India, then of course that would be the another vaccine where it could be available to Indian population if it's imported and used in our country?
Two issues, Dr. Lalwani, regarding the Pfizer vaccine. One is the storage, because I know they have relaxed the storage for about a month. So under normal circumstances. But do you think that creation of this cold chain is going to be easy?
I think the success of both the vaccines which are used in India of AstraZeneca and the Covaxin has been the temperature storage of 2 to 8 degrees centigrade. But the another vaccine which would find its easiest way, and I think I have been having a dialogue with the Serum Institute, is the Covax. The Covax is a very long shelf life as compared to the AstraZeneca and the Covaxin in India, which as on today, the printed shelf life is 1 year, but the Covax shelf life is much longer. So I think whatever data has been coming out for Novavax looks to be a promising vaccine if it gets licensed into the pediatric population.
Thank you, Sanjay. Dr. Jacob John, I have a little problem with the DNA vaccine in children. So do you think that it is safe to give it in children?
There has not been any precedent of a successful DNA vaccine that has been given in large numbers of children. There have been experimental vaccines and results have been disappointing with most DNA vaccines. So we don't know much about DNA vaccine. This DNA vaccine is an intradermal DNA vaccine. So it has got to be injected intradermally, and therefore for consistency of administration, as Lalwani said, you have to use an injector with a certain specific force so that it goes to the right level. We have to wait and see. The trial included children, and we'll have to actually wait and see what the trial numbers are, the trial results are. Just because it is a novel technology, we need not be skeptical about it. When if this is approved, it will be the first DNA vaccine and globally for a pediatric or any adult use. So we'll have to wait and see for more data.
So it is a novel vaccine with a novel way of administration. So we really have to wait and see how it is going to perform in the field.
Yes.
Right, sir. Thank you.
Jagdish,
yeah.
I think just of the this thing, when we were conducting this trial for Zydus Cadila, and we were screening the children above the age of 12 years prior to giving a vaccine for the COVID antibodies, to surprise 1/3 of the population came out positive for antibodies, and I think they had asymptomatic infection. And I think the 1/3 of the population between 12 to 16 years in the cohort from Pune was already COVID antibody positive. That means a lot of virus has circulated into pediatric population, and a lot of them had asymptomatically got the infection and had the demonstrable antibodies in them.
Coming to that point again, I think the Delhi study, and which has shown from 5 centers, showed almost a 50 to 70% prevalence of the antibodies. So I think that's the antibody, probably many children have had asymptomatic infection. Coming to my next question, and I think again I'm going to come back to Dr. Jacob John. See, normally if a patient has COVID, we say 3 months later you take single dose of the vaccine. Now here you're going to implement vaccination across children, and you're going to give multiple doses. Is there going to be any vaccine-induced problems because of that?
That depends upon each vaccine. We need to collect data. See, in our thinking, we try to accommodate without data, whereas in the West, they will not venture to give to children without clear demonstration of safety and immunogenicity. So we'll have to wait for all these vaccines for such data. As Lalwani said, and you repeated, after the second wave, there is hardly any difference in the seroprevalence according to age. children below 18, children above 18, all have been infected very, very widely. And so many of the children whom we will be vaccinating would be children who already had been silent infection. So that's an issue whether we need to separate out already immune children to save vaccine or not. We'll have to wait and see whether we can use intradermal use of the vaccine so that it's both antigen sparing and if there is any adverse reaction, we would be reducing by the dose of the vaccine. All these are in a flux. We'll have to wait and see for more data.
Thank you, Dr. John. So I think we'll move this. So I think we'll come to Dr. Sanjay now. I think he's been quiet for some time. So let's look at what do you think could be the possible harms of the COVID vaccines? I mean, we look at short term and long term.
Jagdish, what is very interesting about these vaccines is that in a short duration of time, large populations across the world have been vaccinated, and we have enough data about the adverse effects following vaccine. So the short-term effects of the vaccine, I wouldn't call it as harm, I would call it as side effects of the vaccine. Generally, these vaccines do not cause serious problems. Most often the side effects are, the adverse effects are non-specific in terms of pain, tenderness, fever for the people who have been administered the vaccine. There are some short-term harms described with specific vaccines. Anaphylaxis could happen with the antigen or with the promoters in the vaccine. In addition to anaphylaxis, there are reports of myocarditis with the mRNA vaccine, which are more seen in individuals who are young and more often in males than females. Whereas with the vectored vaccines, the TTS, the thrombocytopenia, thrombosis syndromes have been reported, especially with the AstraZeneca vaccine and the Johnson vaccine. They have been reported more in women and who are young. There are also some reports of adverse neurological syndromes like the Guillain-Barré syndromes and transverse myelitis, just like any other viral vaccines.
So I think the important take-home message is that most of them are safe. However, we need to keep a watch on side effects because these are new vaccines in a new population. So I think we need to be careful about and watch for any unusual symptoms or unusual signs that may come up. Thank you. So, I mean, this is a big problem which we have, that there are statements like natural disease produces more robust immunity than vaccination. So should we really, how do we really say what is the risk-benefit ratio of a vaccine?
Okay, the risk-benefit ratio requires assessment of the risk. So if you did not have adult COVID disease at all, and we look at pediatric COVID, it's not a vaccine preventable disease in terms of the prevalence or incidence. It's a, okay, COVID disease, not infection. So therefore, assessment of the benefit risk is not going to be easy. Because of the age determined severity of COVID disease and mortality, it's predominantly an adult problem. It's different from the usual diseases against which vaccines had been available for a long time. So the essential role of the children's vaccination against COVID is when you want to reduce the incidence of coronavirus infection in the community. That's when we like to roll it out to children for public health purposes. But before reopening schools, the Maharashtra state has vaccinated all staff of schools, teachers, ancillary staff, bus drivers, etc., in preparation for reopening schools. I think reopening schools without vaccinating children is going to be a bit risky. So we may have to think in terms of the extra benefit in terms of the vaccination in children for public health purposes also. the argument that natural disease is better than vaccine immunity is an age-old problem. People said it about measles, they said it about whooping cough, said it about rubella, and we have grown out of that. The whole idea of a vaccine is that you have a immunostimulant with no risk of disease. And no risk of disease is why we are interested in the adverse event. If adverse events are more in frequency or severe in or problematic in severity, then you have to stop back and think as to what is the safety issue. So in terms of risk and benefit as of now, with the available information, if the vaccine is safe, then the benefit far outweighs any possible risk as of now in our present day knowledge.
So I think here the question should be whether we can prevent basically community infection rather than the individual protection. So I think
Yes.
that may be the okay. I was just coming to you. Just mentioned about schools, and I said, can the government mandate vaccination, Dr. Lalwani, for especially prior to school? You're in Maharashtra, so can they make it compulsory? Supposing one school says we don't want to take the vaccine, what do you do then?
Yeah, when it comes to a pediatric and vaccination to a school-going children, and as Jacob John sir said, from the public health perspective, whether we like or don't like, pediatric vaccination would have to be done before the child goes to school for two reasons. The parents would not send the child to the school unless he gets the vaccine. And I think we need to break the chain by giving even the dose in the pediatric age group. The question is when it will occur. And I personally think so. This should be in the next year, the vaccination would be a part in pediatric age group. And which vaccine will come first, how it will be available, how it will be rolled out. I think we need to see about it. But vaccination would be a part of a national program before actually the school opens in every state. That's what I personally think so.
So I think what Maharashtra has done should be followed by other states also, that all teachers, all support staff, all administrative staff in schools should be vaccinated well in advance.
I think it will go the same way. That's what I frankly think.
Okay, so that's a very comforting thing. Okay, now Dr. Sanjay, there are large number of children in our country who are immune suppressed, chronic disease, malnourished. Should they be prioritized? Because as Dr. Sanjay said, we won't get vaccine for everybody. So I think should we start prioritizing children who have got problems with disabilities, immune suppression, chronic disease, malnourished, difficult to reach population? Should they be priority for vaccination?
Absolutely, Jagdish, but we need to weigh also that the response to vaccination may not be the same as it occurs in healthy children.
True.
These children need to be prioritized because these children are those with comorbid conditions whom the disease could be severe. But at the same time, we need to be sure that the vaccine is effective. So at the moment, we do not have any studies related to the use of COVID vaccine in immunosuppressed chronic individuals, though in adults in chronic diseases, COVID vaccines are found to be effective. So that is my take, Jagdish.
Yeah, I think the studies have shown that many of these patients who have been transplanted will need an additional dose or an additional couple of doses to keep their immunity going in addition to what has been recommended. Dr. Jacob John, do you think that the COVID vaccine will perform the same in a well-nourished compared to a malnourished child? Do you think there may be issues there?
From an immunological perspective, I'm not that worried about malnourished children. They usually have robust immune responses. I'm only worried about overnourished children, that is obese children, who have a greater risk of severe disease. We need to investigate whether obese children will respond to the vaccine as well as well-nourished, normally nourished children. And children with malignancies on chemotherapy and immunosuppression, all those kind of children are at risk for severe COVID, and therefore some kind of prioritization will have to be developed by clinical people in terms of giving them priority. And I suspect that all adults above 65, men, all people with comorbidities may require a booster dose for improving their protection. Again, that is also something to be investigated. Right now, people are looking at healthy people and their vaccination. Definitely, those with comorbidity are also protected, no doubt about that. But a lot of people, men versus women, there is a distinct difference in the immune response, better in women than in men. So can we get more benefit out of immunization by a booster in that small percentage of people who still have less protection than others? That's to be investigated and to be seen later.
Thank you, Dr. Jacob John. Dr. Sanjay Lalwani, any studies on boosters?
Not yet.
Not yet.
Not yet. Not
Okay.
yet.
Okay. So let's get to the thing. Now another problem is in adults we are tracking vaccination by with a COVID app and putting that in. In children, how do you plan to do it? Because many of them don't have Aadhaar cards. I mean, most of them don't have Aadhaar cards. So Dr. Sanjay Lalwani, how will they be? Are they planning a central registry where they can track all these children? Yeah.
First and foremost, first time actually we have seen such a central COVID app by Government of India, and I think it was a Herculean task, and I think they have done it quite efficiently. That's number one. Number two, in the COVID app, if the particular individual doesn't have an Aadhaar card, they can link it with any other government, like their driving license, or it may be even his PAN card. Now, when it comes to, it is always better to have a central registry. I'm sure they are working on it. But I think if the child is lesser, they may have Aadhaar or may not have Aadhaar. They may probably link his to its birth certificate is what I personally think so. So I think making Aadhaar, I think most of them make Aadhaar card. But if there is no Aadhaar card, they would link it to the birth certificate of the child. And that's what I think so when it rolls out. But whenever the pediatric vaccination will roll out in the country, I think it will be through the COVID app only. It's going to be rolled out. And there would be a central registry. And if there is no Aadhaar card, the next important document, of course, would be the birth certificate.
Thank you, Dr. Lalwani. I think this is going to be a major challenge because tracking these children is going to be very, very challenging, especially if you're going to go in for a Zydus Cadila vaccine, which is going to be 3 doses. So tracking them over 3 doses may not be a very easy thing to do. Now coming to Dr. Sanjay Srirampur, another problem with our country is that the compensation is not there for an adverse reaction to a vaccine. So you think that that should be one of the things that should be highlighted to the government?
I think it should be there, Jagdish, because ethically also we have circumvented some of the steps which should have been followed. A compensation in some way is necessary because that will give more amount of confidence.
Dr. Jacob John, your thoughts on compensation?
It's a tricky issue, very tricky issue, because the moment the government agrees on a compensation, it's ipso facto declaring that there could be problems. We have always been saying the vaccine is completely safe. And so our people are not that discriminative to understand that on the one side, vaccine is very safe, and on the other side, you have compensation for adverse reaction. So it's a very, very tricky issue, and we have to think through it very, very carefully. And no other vaccine has compensation in India, and which is also a problematic issue in terms of some vaccine. So I don't think compensation should be brought up with the COVID vaccination at this particular time. Compensation issue should be looked at it on a generic basis for all pediatric vaccines together, or all vaccines together rather than specifically address COVID vaccine alone. I think that might backfire. So it's a very complex issue, right?
Yeah, Dr. Lalwani, please come in.
I think as far as the COVID vaccine is concerned, it's come in a span of 1 year, all the phases at one step. And I think rare adverse events will only come in the forefront when we have the phase 4 of the post-marketing surveillance program, and that also in a country which has a robust system. That's number one. Number two, all these vaccine manufacturers have written to government, including Serum Institute of India, that if there are any issues, vaccination in the phase 4, then those vaccine companies should not be held responsible, and even government would compensate. Please try to understand, this has been a specific situation of pandemic where the benefits outweigh far more than whatever adverse events if they surface out later on in the field. So I think as far as COVID vaccine and what Jacob Johnson says, and I think none of the vaccine manufacturers, they want actually a free pass from the vaccine. Vaccine manufacturers really do not want to be responsible for it. And I'm sure government also will not look at the compensation part of it as far as the COVID vaccination to be rolled out in India. I think that looks quite clear to me actually.
Yeah, I think that's a very valid point. And I think both Pfizer and Moderna have asked for indemnity clause as with the government, saying that we should not be, if there is any court case or anything, we should be indemnified against any side effects. I think that's a very valid point. Now coming to almost the last part of our discussion, there was some discussion which was asked about, do vaccines against influenza protect against severe COVID? Dr. Lalwani?
Yeah, I think there has been a sudden rush of patients, of the babies' parents coming to a pediatrician to take COVID vaccine, saying that they have heard it prevents getting infected. I think the studies done and which are now available, they followed up the two cohorts, one which took the COVID, flu vaccine and they got COVID, and the one who did not take the flu vaccine and got COVID. I think those who did not take the flu vaccine, the complication rate due to a COVID was at 20% higher in those who did not take the flu vaccine. So the problem immunity, that's number one. Number two, by not having flu, by taking flu vaccine makes that particular candidate much more fitter so that he gets lesser complication of COVID. As such, flu vaccine and COVID has no common things in it, but whatever data is available, those who took a flu vaccine and they got a COVID, the complication rates due to a COVID were a much lesser. The simple explanation can.
Thank you, Dr. Lalwani. I think Dr. Jacob Johnson should comment on this. Yeah. So Dr. Jacob
number
Johnson,
one.
Two things. One, the Maharashtra has a committee appointed to look at pediatric response to pediatric COVID, and that committee has recommended flu vaccination. And in Maharashtra, there is the demand for flu vaccination in children. And surprisingly, and I think Tanu Singhal referred to that, there are a lot of co-infections with influenza and coronavirus, because influenza is a fairly common infection. So the co-infections is probably the mechanism by which influenza vaccination reduces the severity of COVID in children. So influenza vaccination is good in its own right. I think we should not project it as a COVID vaccination. It should be influenza vaccination, and influenza vaccinated people have less chance of co-infection with influenza and the coronavirus, and therefore likely to be less severe morbidity, a combined morbidity of both are cytokine storm kind of diseases. So from a common sense point of view, that's a good idea.
Sanjay, what about MMR and BCG? Is it the last word, or shall we bury it now?
I think when we have other vaccines, when we are talking of COVID vaccines, talking on MMR and BCG as repurposed vaccines, whether we would like to bury or not, already they are getting buried.
That's good. Thank you. One last question to Dr. Jacob John. Should each state be given an exclusive branded vaccine? Like, for example, let's say Tamil Nadu gets Zydus Cadila, Karnataka gets Bharat Biotech. So that you can do a clinical trial over a period of time and see what happens with the COVID disease. Is this a possibility?
Possibility, yes. Probability, no. Because that is not the way things should work out, because what language do you speak, which state you live, therefore you get, no, that's not the, I think there should be a uniform approach, and some choice should be given to communities, essentially, when there's a glut of vaccine. When there's a shortage of vaccine, then of course the allocation depends upon the availability of vaccine. But it's a bit too premature to look in terms of whether an experiment can be done by giving vaccine A to state A and vaccine B to state B and see what happens. I don't think they'll be comparable also, because there are a lot of variables, and both in data collection, robustness of data, etc., etc. So it's it theoretically seems good, but in practical issues, I don't think it will pan out to be a realistic issue.
So it's a utopian dream, huh?
Yes.
Okay. Now, quickly, I will just go through this now. This should only the government give the vaccine, or should all the private practitioners also be allowed to give the vaccine? Because right now the government is treating it as some kind of property which they want to hold.
That is because the emergency authorization still is valid. It's not licensed. So therefore, government is the agency that should decide who gets the vaccine and who does not get the vaccine. So the power is given to the government by the Drugs Controller General of India to choose who gets vaccine. So it's not, until licensing is done. As I said, both companies have applied for full licensing. It's only now Covaxin people have gone to WHO for WHO approval. We hope it will be through by August. They may get approval because they have already submitted the phase 3 trial data to WHO. So all these are in a flux. Let you wait and see.
Okay. So now I think before we end, this probably is my last question. Any future vaccines, Dr. Sanjay Srirampur?
Yes, they are in phase 1 studies, Jagdish. The nasal vaccine, especially the Bharat Biotech one, it's in the phase 1 studies. The advantage would be that it is supposed to reduce the transmission. It is supposed to give local immunity, and it is also easy to administer. The influ combo vaccine is by the Novavax company, which is also under phase 1 studies in hamsters, in animal studies.
So still long way off, at least another couple of years.
Yes. There's a rider.
Yes, sir.
As far as I know, the trial that is going on is 1 dose of Covaxin followed by 1 dose of intranasal.
Okay.
It's not a intranasal alone. Intranasal alone, I don't think had sufficient immunogenicity to take it forward. But when you give 1 dose of Covaxin followed by 1 dose of intranasal vaccine, I think they have excellent immune response.
Thank you. Thank you, sir. So I think before I end this session, I want 2 recommendations from each of you for everybody. So we'll start with Professor Jacob John. 2 recommendations from your side.
Recommendations to who?
To all the listeners.
Okay. Well, watch the horizon as to what developments are coming. One day, children's vaccine will be made available. So be prepared for that. But as of now, what recommendation can we give? Continue the COVID appropriate behavior and prevent infection as much as possible. Vaccine is yet not available. It's on the horizon for children. So no recommendation.
Okay, sir.
Except be prepared.
Dr. Sanjay?
Advocate vaccines in adults, Jagdish, that is recommendation 1. Advocate vaccine for the ancillary staff in the schools, because that is one thing which we are neglecting, because children are missing their schools since the last 2 years. Vaccinate adults, and as and when recommendations come for the pediatric vaccinations, advocate.
Right, sir. Dr. Sanjay Lalwani.
Now, I first and foremost, as a pediatrician, we must sensitize the parents of the child to take the vaccine, and I think we should do our best to see that maximum of them whom we come in contact, we give a positive impulse for taking the vaccine. That's number one, including the lactating mothers. And second, I think the world and a country like ours, each and every person on the country has realized the importance of vaccine. I'm sure the good way to take COVID pandemic would be the vaccination rate in India subsequently post-COVID would really go up. And I think it will not be only a pediatric vaccine, it will open the other horizons like the adolescent vaccine, the adult vaccination, and geriatric vaccination in years to come.
Thank you, Dr. Lalwani. And I will stop here and hand it over to Dr. Ramachandran. I think we have finished on time, Dr. Balasubramaniam. So I will hand it back to Dr. Ramachandran.
We are trying to finish the question.
Thank you so much. Thank you so much, Dr. Jagdish. Really, I appreciate you and all the esteemed panelists for doing justice to the topic and doing it in time. Can I just roll through some of the questions? The question 1 is, can COVID vaccines come under the ambit of Pandemic Act in the interest of the community to protect the community? Just as you say, mask and other these things, can it be enforced? Because of the hesitancy and other issues involved.
Most unlikely, because you see, Supreme Court said something about the that religious pilgrimage right now, and people are objecting to that. So anything that is compulsorily mandated is not going to be a good idea. You have to educate people and get their goodwill and acceptance.
Thank you, sir. Dr. Sanjay Lalwani, what is the storage temperature for Zydus vaccine?
It's 2 to 8 degrees centigrade.
Okay, same as this thing.
Yeah.
I think this has been addressed, but if you think it has been taken, with high levels of antibody, nearly 50 to 60% children and adolescents, any vaccination is going to may act like a booster. Will it increase the reactions like MISC? So antibody enhanced reaction, will it be there?
Doesn't appear so. I think we have to just wait and watch. But I think anybody who has got COVID subclinical infection and antibodies, I think whenever the pediatric vaccination gets available, I think the adolescent needs to be vaccinated.
Right. I think Dr. Tanu Singh will also refer to this in a talk. Okay. If pediatric COVID vaccines are delayed due to availability, all not till next year, probably COVID pandemic will be no longer will be there. Just like like H1N1, it may become a kind of endemic. What's your comment? Are we waiting? I mean, by the time it's taken up for children, it may not be required. Is it likely to be a scenario like that?
Let's pray for that and work towards the vaccines. Let's pray that it disappears by the next year.
Yeah. I have one question of my own. What about changing of the vaccine, especially with the viral vector vaccine? The inherent Sputnik is a different vaccine. The studies which are going on, what is the scientific information available so far? So mRNA to AstraZeneca's like this, or AstraZeneca's to mRNA, other way around.
I think there are
any available information.
Yeah, I think
is it an advantage to give a different vaccine or no?
You mean
I think there is
vaccine? Is it one dose of one vaccine, second dose of second vaccine? Is that the idea?
Yes, sir.
Yeah, I think.
Some studies are going on, and as long as all vaccines are spike protein specific, interchangeability is not a big problem. And there seems to be some advantages in the limited studies data that are available that it broadens the breadth of coverage. That is, the coverage of newer variants seems to be slightly better when you give 2 different vaccines in the schedule rather than 1 vaccine as full schedule. These are very preliminary information that we have. But if you get 1 vaccine in a country and you travel to a second country, another vaccine is available, the recommendation is to take that vaccine in that country. So there is no immunological problem in giving different vaccines sequentially. Advantages, we'll have to wait and see. There seems to be some advantage, especially the coverage of newer variants seem to be slightly better.
Yeah,
But
I think so. Dr. Ramchandran, I think the study which Dr. Jacob John said about the vaccine first dose and second dose, I think what they are looking at, the study of the Pfizer vaccine followed by AstraZeneca, I think that's the common interchangeability what they are seeing globally now. And as Sir told, likely their mechanism of action is different, and I think it's spike protein related. Ideally it should, but they are looking at the combination of the vaccine and does it have a better immune protection? We just have to wait and watch. It's too early to comment.
Can I answer this question?
Sure,
this is
sure.
Tanu here.
Please come in.
Yeah, so there is the COMVAC trial which was done in Britain, which was a randomized control trial in which they had 4 groups: Pfizer, AstraZeneca, Pfizer, and AstraZeneca. And what they found that AstraZeneca best was with Pfizer, followed by AstraZeneca, Pfizer, and Pfizer followed by AstraZeneca didn't give any benefit. But the best T-cell responses were seen with when AstraZeneca was followed by mRNA vaccine. So the only problem is they found that when the second dose was a heterologous vaccine or a different vaccine, the side effects were a little more.
Okay. If I can add here, Dr. Tanu, they were only short-term side effects.
Yes.
PRC, the last question, because Dr. Jacob John has to join the Telangana session at 8 o'clock. That will be the last question.
Sir, I don't see any other questions which are of very important nature in the question box. Other things have been covered by other topics. Dr. Jagdish, if you want to conclude by saying something, it's your time.
Yes, sir. Thank you so much. I think I must thank all 3 panelists for a wonderful discussion on the COVID vaccine when it comes for children. And I think the important thing right now is that we still are awaiting a lot of data. We do not know too much about the vaccines in children. However, some of the vaccines have got good trials which have been done abroad. Some of the Indian vaccines also are submitting their data in children. So we'll wait closely in the next 2-3 months. We will know how this vaccine is going to roll out. But I suppose in the meantime, we should continue to vaccinate all adults and all people who come in contact with children, because that is very, very important, whether they are school, elderly, grandparents, servants, anybody coming in contact with children should be vaccinated with the existing vaccines. It doesn't really matter which vaccine, because all vaccines have been shown to be equally efficient in protecting against severe disease. So I think these are some common things. A lot of intricacies will be sorted out over the next couple of months or years. We really don't know.
Thank you, PRC. Thank you, Dr. Ramchandran, for the excellent session. Thank you all, particularly Professor Jacob John, in spite of his busy schedule, he could join. Thank you very much, sir. We move on to the next session. We have an international speaker, Professor Ramanan, waiting for long. The moderator for this session is none other than Professor Thangavelu, the head of the department of pediatrics of Dr. Mehta's Children's Hospital. Over to Professor Thangavelu, who doesn't need any introduction. Over.
Thank you, sir. Good evening. Thanks for the opportunity. Next session has got 2 important topics.